Hello and welcome to this webinar. Before I hand over to my moderator and colleague Maitreyi, I would like to briefly present some information about the Center for Data Science and our health team, which is hosting today's webinar. So my name is Professor Sandeep Reddy. I'm the co-lead for the Health, Human Biology and MedTech team in the Center for Data Science. Before I go ahead, I'd like to acknowledge the traditional custodians of the lands on which we gather. Here in Brisbane, we acknowledge the Turrbal and the Eora people and acknowledge the elders past and present. And if any of you have Aboriginal or Torres Strait Islander descent, I also acknowledge you. So as I mentioned, the Centre for Data Science is hosting today's webinar, and the QUT Centre for Data Science is across the University Tier 1 Research Centre, and we serve as Australia's centralized hub for world-class data science research, which also draws on capability not just within QUT, but across the nation. Our vision is to be a global leader in data science and artificial intelligence methods and practices that benefit the world. And within the QUT Centre for Data Science, we have 6 principal research areas, and one of them is health, human biology, and medtech. And our team's vision is to transform healthcare and advance human biology research through innovative data science and AI approaches that lead to improved health outcomes, more effective treatments, deeper understanding of biological systems, and accelerated medical technology innovation. However, it's not just enough to have a vision, we need an implementation path. So underpinning the vision are 6 key pillars. Firstly is the computational innovation, where we pioneer novel computation methods to analyze large-scale data sets, but we also engage in interdisciplinary partnerships, not just with disciplines within the university, but also domains across the industry and different sectors. And further to that, building on that, we are also very focused on translational aspects, where we just don't want to focus on the theoretical, but also take whatever we develop in the university, in the academic sector, and translate it into the industry. Building on that, we also get involved in software as medical devices and other medtech innovation. And further to that, being an academic research center, we're also interested in educating the workforce in emerging technologies, including AI. It's also important for us to ensure that when AI gets used or emerging technology gets used in healthcare, it's responsible and there are ethical safeguards. So in relation to that, we also get involved in developing responsible AI and governance frameworks in relation to that. In relation to today's webinar, in our team, we are really focused on translation AI, as we discussed, but we are also interested in today's speakers who are eminent people who are engaged both in the theoretical and in the application end. You'll hear more of them soon, but we are very, very privileged to have them. And finally, if you're interested in the Center for Data Science and knowing more about our health team, do reach out. We have left our contacts there. With that, I would like to hand over to my colleague and co-lead, Maitreyi.
Thank you, Sandeep. Hello, everyone, and welcome to our seminar on Health AI, Human in the Loop. So as Sandeep mentioned, I'm Dr. Maitreyi Velmurugan, and I'm the ECR co-lead for the Health, Human Biology and MedTech team within the Centre for Data Science. So one of the things that we're seeing more of a trend in is that artificial intelligence is increasingly being used in health applications, but we still find significant challenges when we're trying to use AI in a human-centered way. So today we have 2 fantastic speakers who will take us through their views and their experiences with health AI. So I'd like to extend a very warm welcome to Associate Professor Charlie Corke and to Professor Tim Miller, and I'd like to thank them for taking the time to be here with us today. Now, as we go through the session, if anyone has any questions for our speakers, please post them in the Q&A and we can address them at the end of the session. So up first, we'll hear from Associate Professor Charlie Corke. So Associate Professor Corke is an intensive care specialist, a renowned communications teacher, and the creator of ClinicalAvatar. He was one of the 3 founding intensivists who established intensive care in Geelong, and he's previously served as the Director for Intensive Care at Geelong Hospital. He's also been extensively involved with the College of Intensive Care Medicine, and he's a strong advocate for medical communication training. Associate Professor Corke was actually the originator of the college's communications course. So please welcome him for his talk on adapting medicine for an AI world.
Thank you very much. I hope you can see my slide.
Yeah.
So my first slide. So I'm going to come very much from a medical perspective. Obviously, AI is something that's very come at us really very quickly. It's amazing, but it's a bit scary. So this is my AI image of how it feels in medicine at the moment. So just to walk you through a few of the things that are happening. I mean, the first thing that I observed is the clinical practice transformation of automation of administrative tasks. So the big one that came up first was the thing about general practice and note-taking during general practice. Over the last few years, with clinical information systems, GPs and doctors in general have been spending their time typing as they talk to patients. So they're not looking at patients, they're looking at the screen and typing. And doctors hate it. They don't really like typing. The patients hate it because the doctor's not looking at them. And if the doctor leaves it and does it after the patient's left, then it's waste time. And the new systems for automated note-taking have really been taken up hugely. And there are a lot of providers, a lot of general practice are using them. There's virtually no regulation around them, but they're so fabulous that they've just taken over. And I think that gives a bit of a flavor of the way in which this technology is leaping ahead of all of the organizational things. I'm sure Tim's going to talk about that. Discharge summaries are also appalling. At the moment, we just bring all the information that's happened to a patient, we stuff it all together into one long document without any real curation of it. The doctors may delete a bit and add a bit, but it's pretty messy, and there's clearly a big role for intelligent discharge summaries, and doctors loathe doing them, and as soon as that comes and will efficiently just do the discharge summary, the happier they'll be. Decision making, prognosis, risk estimation, and treatment planning. Again, that's pattern recognition, and AI will do it a lot better. It's already, so for here with risk, this is off my phone where I have MedCalc, which is the calculations for risk that you can see here. There's 168 different calculators for risk, and I'm not going to know them. I'm hardly going to even use them. Although they're all there, we don't use them because we can't, but AI will and can. So getting risk assessments and planning treatment, individual treatment is clearly coming. In diagnosis, in radiology, dermatology, histology, and other things, pattern recognition AI is amazing. It's already been shown that for mammograms, which are quite difficult to interpret, AI does better than experienced radiologists in picking up early cancers. So radiology is all pattern recognition, and AI will love it and is already taking over. And I personally, so people ask you, what's the moment you knew that this is something that's time has come? Well, the moment I knew. So I work in a little emergency department, only 4 beds in a little country town where I live. And there was a holidaymaker on a bus trip with 30 others who were mostly elderly ladies. So I've given you a little illustration of elderly ladies happily on the bus there. He was a single man from Holland. I don't know what he was doing with this lot, but anyway, he'd booked on this trip, and he presented to me with a widespread, itchy, painful rash. And it started on his face and spread rapidly across his body, and he had lesions on the palm of his hands, which is very unusual. And it made me worry about what this was. And then what I worried about was Mpox or monkeypox. And it's often begins on the face, spreads over the body, and it characteristically includes the palm of the hands, which other rashes don't. And it starts, and it's the trouble is that it's it's the high risk patients need to be isolated. It's something we're worried about. And he'd need to be isolated in a single room for 21 days, and he's on a bloody bus trip with all these old ladies. What am I going to do? And I've got to talk to him about this. It's a sexually transmitted disease. I've got to talk to him about his sex practices. Everything is bad about this bloke. So I showed it to my colleague, who said, yeah, Charlie, I think it might be the GP who's in the town. But he said, I've never seen it. I don't know. But he'd had a friend who's a dermatologist, so we sent it to the picture to the dermatologist, and 5 hours later he hadn't answered me. But at the end of the day, his receptionist rang and said they thought it was bed bug bites, but it was 5 hours later. Now, I hadn't waited 5 hours. I mean, the bus was revving outside, for heaven's sake. There was no 5 hours. So I put it into ChatGPT and I put the picture in. It told me with a differential diagnosis, insect bite hypersensitivity as the top one. The next one was a chronic irritation. Well, it had come up explosively over a day, so it wasn't that. Scabies, and I know how to look for scabies, and he didn't have scabies. So it looked really like it was insect bite hypersensitivity. I asked ChatGPT a couple of other questions to ask him to sort it out, and it told me what they were. He answered. It was all fine. It was all insect bites. And he got back on the bus and he carried on. And I didn't cause havoc across Victoria by saying I had a patient with monkeypox who'd infected potentially a whole load of old ladies on the bus. So, it was amazing, and it was correct, and it was quick. But of course, the thing is, I'm not allowed to use it because it's all terribly bad. Digital triage will happen. Not getting triage right. We hear about these patients all the time who come into hospital and do their triage, and they get put in the wrong category and they die in the waiting room. So it can easily happen.
Today. Well, I've got this really sore ear.
I'm sorry to hear that your ear is sore. Have you noticed any other symptoms, such as fever, trouble hearing, or any discharge?
So it's very straightforward, and I can see that being being helpful very quickly. The next thing that this is what I've been doing about education, to use AI to create patients that you can talk to. Getting doctors to improve their communication skills is hard. We have actors who come in, and facilitators who help them to tell them how to speak. But AI is amazing to do it. So here's a chap that is just a brief introduction to.
I've had to come in as I've just got no energy now. I'm just not able to manage doing anything useful.
Oh, Ronnie, I'm sorry to hear that, but I hope that we can improve things for you.
Cheers for that. I reckon improving things would be a fair outcome, but I'm not holding my breath, literally. Just want to keep things as comfortable as possible.
And I can make them have all sorts of characters. We can make them be reluctant to accept things. We can make them argumentative. You can do whatever you like. And the other big advantage is that afterwards, we can get them to give us feedback. So this is one where I've done a fairly bad job of talking to this lady about her plans for the future, given that she's got a very severe illness, and is likely to get into a lot of trouble quite soon. And I've tried to have a conversation with her to work out what we should do when the next attack happens. And then she can give me feedback from AI.
Could we please stop the conversation, and could you give me feedback, particularly focusing on my use of adjectives and whether I could use clearer adjectives?
Of course, I'd be happy to provide feedback. From Mary's perspective, I appreciate your effort to communicate with me. However, There were moments when the conversation seemed a bit unclear due to hesitations and incomplete sentences. This made it challenging for me to fully understand the situation and what you were trying to convey. Now, from a communication content expert's perspective. Introduction. You introduced yourself appropriately as Dr. Brown. Permission. You attempted to seek permission but could have been clearer in your request. Clarity of English expression. There was some lack of clarity due to incomplete sentences and hesitations. Understandability. It would help if you avoided vague terms like quite bad or might die. Instead, use more precise expressions such as really bad or there is a significant risk. Hesitancy.
And the big advantage of this is that the doctors can do the training whenever they want to. They can do it as much as they like. They can repeat doing it. And they like the avatar giving them feedback. They're much less threatened about the avatar giving them feedback than they are about me giving them feedback. So, and we can calibrate the avatar to be more gentle or more forceful, or we can tell it to pick the major the one major point for them to work on, or we can offer a whole range of other points. They can query the feedback they get back. It all works incredibly well. And of course, the other thing is that it can be done it's really easy in AI to get it into other languages. I've got a talk to do in Thailand. They've got some really big problems about not withdrawing treatment that's ineffective in Thailand, and it's doing very bad things to their budget, their health budget. So this is an avatar I've just switched to Thai language, and he's been spoken to by a colleague of mine who's a Thai doctor. So it's very easy.
ครับคุณหมอพยาบาลบอกว่าคุณต้องการคุยกับฉันใช่ครับคุณสมชายครับคือหมอมีความกังวลใจว่าอาการของคุณพ่อของคุณค่อนข้างที่จะหนักนะครับแม้ว่าจะได้รับการผ่าตัดหัวใจแล้วครับ
I won't inflict Thai on you for too long. But it's very easy, and he gives his feedback in Thai, so the whole thing can be switched over to other languages in a flash. So it's incredibly powerful and exciting to transform education, which in the past has been very limited by cost. Actors are costly and facilitators are costly. Trying to standardize things is difficult. It costs about $1,000 for a half-day course, whereas the AI is very cost-effective and can be tailored again to the person. We can adapt it very easily to the person who's to their skill level once the AI picks up on their level of skill. We've got lots and lots of different avatars so they can look real and effective. And that's the other thing. The actors I've got are all very young. So I have to say, this 25-year-old actors, pretend they're an 80-year-old woman. Whereas the AI, I can make them look the way they should look, which is all positive. There are clearly issues with integrating AI with medicine. So this was a study in JAMA recently. So AI scored an average of 90% diagnosing an unusual medical condition from the patient's case notes and then explaining its reasoning. It got it right 90% of the time. Experienced doctors who had access to AI got it right 76% of the time. And doctors on their own got it right 74% of the time. And this study sort of failed because they thought what was going to happen was that the doctors with AI would be better because they'd be correcting the AI errors. But of course, it wasn't that way round at all, because doctors have strong but incorrect belief in their diagnosis, and they didn't listen to their AI even when the AI was right. The other problem I'd see is that allowing, like with my MedCalc, where I've got a lot of options of what I can use of all those calculators, I just don't use it. So doctors have to give the information. If doctors are left as the people who've got to put the information in, they won't. They'll be selective about the information they put in. And if the AI has half the information, it'll give a rubbish answer. It's likely to give a rubbish answer. So there's a big problem if we leave the doctors to control the AI. And I'm sure a lot more of that from Tim later, but that's a big issue for us. The trust and the things is a problem. Who'll be liable? My hospital has banned all use of AI, which of course is a complete non-entity, a madness, because everyone's using it on their phones all the time. So, you know, banning it's not a solution. I would imagine that I would give AI indemnity insurance because I think it's a lot more reliable than doctors. So we need it today, but I'm not sure who owns the responsibility, and that's going to be an issue. And you know, where is the large language model that we're using? Because I don't even know where mine's going. And the normal governance creation processes in hospitals are incredibly slow. Government ones are worse, and God knows how we're going to manage it at a thing that like with that train coming down the rails. So, but I hope that it's not going to stop us, because I can see personally as a clinician a great problem if we're told not to use something that we're going to use, because we will. And the data governments, I mean, protection of sensitive health data is essential. Again, where does it, all the data needs to go in, but it has to be secure. So where's the server, who's got access, and what happens to the data after it's been analysed? And I just don't know the answer to any of these questions, which is why I'm glad other people are doing it. So my take on regulation and government is that currently we've got doctors who are independent. They make up their own minds about things. They're very variable. They're very opinionated. They're prejudiced. They're distractible. They're fatigued, but they're experienced and they're experts in their field. The nurse practitioner because my sister-in-law said the other day, oh, I saw a nurse practitioner. Isn't that terrible? They're so unskilled. But actually, the nurse practitioners are cautious, reliable. They followed protocols which are limited in their scope of practice, and they're somewhat aware of the evidence. But it doesn't really matter because their protocols in Australia are very well written. And AI is the best of all worlds because it's configurable, remembers everything it's taught, it's reliable, it's consistent, it's dependable and auditable. And I see the future as the doctor's going to need to be have much better skills in communication and organisation, and their experience and expertise needs to be moved to advising AI to configure AI properly so that it functions right. So there's a huge amount of work for doctors in actually being involved with configuring AI. So teaching to clinicians to work with AI, how we understand it, understanding how it makes recommendations, what the limitations are, and we're going to have to work with it. And there's a massive change. So teaching knowledge to medical students is probably not going to be the primary thing in the future. But I see it all very positively. My second vision of AI is here with the driver sitting in the train, totally relaxed, and just driving the train. Thank you.
Thank you very much for that, Charlie. That was absolutely fascinating to hear from. I noticed someone in the Q&A had actually said, you know, I sometimes in tertiary education feel a bit like the person in front of the train. So it's good to think about how maybe we can get onto the train. Thank you so much. If anyone else has any questions, please feel free to put them into the little Q&A box down the bottom, and we will go through them all at the end of the session after the second talk. So up next, we've got Professor Tim Miller to talk about challenges with AI clinical decision support systems. So Professor Miller currently holds the TIET-UQ Chair of Data Science, and he is also the Professor of Artificial Intelligence at the University of Queensland. His research combines machine learning, reinforcement learning, AI planning, interaction design, and cognitive science to support better decision-making. So his areas of expertise include explainable AI, human AI mixed initiative planning, and human-centered decision support. Professor Miller describes his mission as improving the capabilities of expert decision makers by using artificial intelligence to do the hard things. So I'll hand over now to Professor Tim Miller.
Thank you. Yeah, so the title of my talk's a little bit different, which is Explainable AI is Dead, Long Live Explainable AI, or the subtext is why your AI decision support tool probably doesn't work for its users and why it's so very hard to get it to do so. And so I'm coming to you here. I'm in Patiala in India today, where I'm kicking off some projects around some of these ideas here. And I'm really, the title of the paper comes from, sorry, the title of the talk comes from a paper that I wrote, in 2023 around this, where I kind of made this claim that this idea of explainable AI is probably dead for decision support. And it got a little bit of traction because this is one of the things I'm really known for around the world is explainable AI. And I sort of made the claim that the way we're doing explainable AI for decision support right now is perhaps not the best way to do things, and we can do a little bit better. And so if you're unfamiliar with the general field of explainable AI, to give you the central overview, it's just really machines that might say give a recommendation for a diagnosis, such as Charlie just showed us here, and then explain why the machine would explain why it gave that particular diagnosis in various ways. And it's a very big field, and people are having some impact in areas, but I think overall the field's not moving in the right direction, including my own work. And so I was kind of inspired to think about this work and to write this paper and to start writing grants around this area by seeing results like this. So this is a graph from a paper of my own, which wasn't a medical study. It was actually a study with the Defence Science and Tech Organisation, where we have a human behavioural experiment where people are using decision support tools. And we can see along the bottom here, if you can see my pointer, we had 3 conditions. It doesn't actually, don't worry about what these are, they're not important, but we basically had a baseline condition and 2 explainability conditions. And when we ran these with expert users and semi-expert users, we kind of see that these tools have very little impact. So sometimes, in this case, the 2 treatment conditions do better, but other times, as we see in this one, they do worse. And I'd like to say this was just a quirk of the experiment design. It might have been, but around the world, we're seeing exactly the same thing in many domains, and especially in the clinical domain. Charlie had this really great study that he showed from JAMA here, that it's just really not improving people's decision-making a great deal. And so what we'd love to see is if we graphed the results of different studies and we had some sort of task performance on the left, which could be diagnostic accuracy or something like that, what we see is we have a person who can do a reasonably good job. They're an expert person, and this quite often we see. Sometimes we can have an AI recommender system it's even better because it's got access to more information. It's really good at recognizing patterns. It's not fatigued. All these other things. And what we'd really love is to say exactly what Charlie said, the author of this paper hope there. Well, if we put a human in the loop, they'll find the mistakes that the AI makes, and together they'll be better. But what we see is exactly what Charlie showed from that JAMA thing is actually looks a little bit more like this. We actually improved people's decision making a little bit, probably not enough that it would be worth the amount of effort we're putting into building these tools, but we're not getting this what we call complementary performance, which is what everybody kind of assumed was going to happen when we started building these things 6 or 7 years ago. And we see this over and over and over in many clinical domains. That's really hard to improve people's decision-making capability. And I mean, I guess the really negative take on it is that that people just make AI worse by interfering. But I'd like to think that we actually can leverage experts in order to help. And so it was this was my kind of claim here, that giving people recommendations such as diagnoses, treatment plans, and getting them to sort of check them is probably not the best way in order to deal with really tricky cases. So generally, I think for really easy cases, that's probably fine. But I think for anything that is a little bit out of distribution, a little bit complex, such as the almost monkeypox example here, that's actually quite difficult for people to do that without if you don't have the expertise, it's really difficult. But even if you do, sometimes it's hard to get people to change their mind. So does this mean explainable AI is dead? This idea of giving recommendations and explaining them dead? Well, let me give you perhaps a little bit of poll. And I don't know if Ashley's here. She was going to enable a poll for me, but let me do a quick survey. So I want you to imagine here that you have a really tricky situation, just no matter what you do in your job. Let's say you have a really difficult situation. So the poll's up there, we'll vote in a minute. You have a really tricky decision to make. So think about a decision right now that you've made quite recently that was pretty difficult. And I want you to imagine you've got two colleagues, you sit in an office and there's two colleagues, one on either side, and you can go and ask them for advice. And so colleague number one here is Bluster. And so Bluster's an expert, and if you go and ask Bluster, he'll tell you exactly what he thinks you should do. And even better, he'll explain why he thinks that's a great decision. And if you say, well, I disagree with you, Bluster will say, no, I really believe that I'm right here, and explain why. Alternatively, you can go to the room next door and you can talk to your colleague Prudence. And the difference is Prudence will never actually tell you what she thinks the answer is. Prudence will say, well, what do you think the answer is? And when you give her the example here, well, I think it might be monkeypox here, she'll say, well, here's some reasons why you might be wrong about monkeypox, and here's some reasons why you might be right. This is why I think you could be right and wrong. And if you change your mind, you say, oh, maybe it's not monkeypox, it's the bed bites or something like that. She'll say, well, here's the reason why it could be bed bites, and here's the reason, bed bugs, and here's the reason you might be wrong. And you can go around this loop several times. And so what I want you to do in the poll now is just answer that question of who would you rather go to if you had to ask for advice on a tricky question where they both have the same level of expertise, similar to the level of expertise you have, but you don't know what the answer is. Okay, great. So we can see roughly around about 80% to 80 to 20 people prefer to ask Prudence for this answer. And so if you're interested, I would like you just in the chat to share briefly why you chose Prudence, say who you chose and why. And in the meantime, I'll just kind of talk through the things that I see here. And so what we see is when I do this kind of survey and talks and other places, I see this kind of distribution here where lots of people say Prudence and a few say Bluster. And of course, it's a completely biased poll because I chose funny names that kind of bias you towards Prudence, but I've seen this run by other people, this exact scenario where they use much more neutral names and they see similar results here. And the kind of things that I see if no one's said anything in the chat here, no one's brave enough to put themselves forward at the moment, I think, because it's a tricky question. The kind of reasons I see people say is, well, kind of Prudence is more like a coach. Prudence is allowing me to own the decision-making process. Prudence is, not telling me the answer. So I actually have to think through the process myself. So it doesn't erode my decision-making ability. But then some people say Bluster, well, Bluster's faster. If I had a very short amount of time, I would do it really quickly. Some people say if it was a pretty low-risk decision, I would take Bluster. And so these are things that I think are really valuable insights into the way people think about decision-making. But the point here is not to say that one is better than the other. I think there are situations where if you ask somebody a question, you want a quick answer, especially if they're the expert and you don't want to develop that expertise. But there are situations where you don't want them necessarily to tell you the answer, or you might want them to, but it's not the best way to do things. The point here is that if areas like clinical decision support and decision support tools generally, we only really give Bluster. We pretty much take a training data set from past decisions, we train it to make those decisions, we tell people the decision, we explain it to them, and we hope that makes them better. And I think that for some types of decisions, in some situations, that we should also have decision support tools that look a bit more like Prudence. Things that don't give the answer, especially if it's not a confident answer in its own machine, the machine's answer is not confident, they don't give an answer, and they help the decision maker by guiding them to help them find the evidence that would support their decisions. Okay. So I guess the question is, so in this case here, I call this recommendation-driven support, where something gives a recommendation, and I call Prudence hypothesis-driven, where one of them is driven around recommending stuff to you, the other one's driven around you providing hypotheses in order to do things. And I envision a situation here where if there's a large set of hypotheses, the tool might help you narrow down, as we'll see in my example later, narrow down these set of hypotheses as well. But really, the reason these tools aren't working in using a recommendation is due to this sort of distrust and under-reliance and over-reliance things. So if you imagine when you use a tool to keep a very simple sort of binary, it's not really this easy, but let's say the tool is either trustworthy or it's not. Here, this is really a sliding scale, but I'm keeping it basic. The tool is, if you imagine a decision support tool, it's either good or it's not very good. And then you can either trust it or you can not trust it, or you can distrust it here. And if we put these two things into a matrix, we get this model of trust that some colleagues and I came up with a few years ago here that says, well, if a tool is trustworthy and you trust it for that reason, this is warranted trust, or you rely on it and it's warranted reliance. On the other hand, if it's trustworthy and you distrust it, that's unwarranted distrust. A not trustworthy tool that you trust, that's unwarranted trust, and that's called over-reliance sometimes. And of course, we've got the final one here, where if it's not trustworthy and it's distrusted, that's very much warranted distrust. And what you really want is you want a tool that people use like this, right? When it gives the right answer, you want them to accept it. When it gives the wrong answer, you want them to be able to reject it. And we kind of felt like the explanations were the way to help people do this. But what we're really seeing is they don't seem to be able to help people make that decision here. So in Charlie's example where he said, doctors have strong belief about their own diagnosis, that's probably justified because they're pretty good at what they do. But what we're finding is when the tool and decision makers agree, it's fine. They just tend to go, oh, great, I'm slightly more confident now. And what we tend to find from observing people in studies, we haven't tested this hypothesis formally, is that when they disagree, they kind of look at the explanation and then they're really unsure about, well, should I trust myself or should I trust this machine? And what we find, especially in areas with high expertise, people say, well, I'm going to trust myself rather than a machine that I know very little about. And it doesn't help these explainability tools, these decision support tools, doesn't help people sort of eliminate that tension and move from one of these two in order to the other one here. And sort of part of the reason I think this works is because we have been thinking about things in slightly the wrong way for a lot of cases. And I want to talk a bit about self-explanation. So self-explanation is really this process here is we've got a person interacting with the machine and you have explanations going back and forth between the machines. You have recommendations and explanations. But at the same time as trying to figure out why the machine makes the decision, the person is also trying to make a decision themselves. So they're trying to do a diagnosis cognitively, and there's a machine that's trying to do a diagnosis cognitively, and they're trying to match these two things together. And so at the same time as explaining the diagnosis to themselves, they're also trying to explain the machine at the same time. And these are two different processes that are running simultaneously that I don't think really interact very well. And they're also trying to sort of verify these models and these outputs at the same time when they disagree with it. And I think this process here of trying to understand a machine and trying to understand a diagnosis at the same time, they sort of conflict. And you're in some sense in the paper, I talk about how you're doing things backwards in some sense. You're trying to understand the machine, you're trying to do reasoning about that in one level, and in self-explanation, you're trying to do that at another level, and they don't match. And so this process of self-explanation is called abductive reasoning. And so I've got a paper on this with some cognitive psychologists from the US. And abductive reasoning is really this simple process where you observe an event. It's the spots on the guy's arms and palms and face. You generate some hypotheses. It could be monkeypox, could be this, could be that. You judge the plausibility of these hypotheses based on the evidence that you know, and then hopefully you can resolve it based on that, and then you can you resolve it by explaining the symptoms, and then hopefully you can extend it later. And sort of what are the requirements you have here? Well, if you want to design a system, you need to determine interfaces to determine what's happened and highlight unusual events. So this would be making sure you can see all the evidence that you need on an interface. You need something that helps you construct the likely hypotheses, monkeypox, bed bites, etc. You need decision supports that help you explore the causes and effects of this particular diagnosis. So we saw in Charlie's example of ChatGPT that's actually one of the things language models are quite good at, is giving the evidence to support things, even though it's wrong some of the time. And then you want to be able to do some other things like administrative things here. And I guess the point I'm going through all this abductive reasoning things, I think that what we're pretty good at, we've got tools that can actually do this already. Find evidence to support and refute hypotheses, explore cause and effects. That's kind of what machine learning is actually really good at, but we don't use it for that in our case. And these tools don't support things often like constructing likely hypotheses. And it's my view that if you took a more prudence view of these tools and thought about these requirements, we'd come up with something a little bit better. So let me give you a quick example of what I think what tools could look like. And it's a framework I've derived that's called evaluative AI rather than explainable AI. So in evaluative AI, you have a decision maker and they have a hypothesis that they think might be the case. I think this might be monkeypox here. And what the tool does is give them evidence to suggest, yes, this is why it could be monkeypox and this is why it might not be monkeypox. And if that evidence perhaps makes the decision maker reflect on their own decisions here, then they think, oh, well, maybe it's something different. Maybe it's just indeed bed bugs. And then it gives this evidence, this is why it could be bed bugs and this is why it might not be. And they can just reflect on this information as they get these outputs. It helps them to sort of reflect things a little bit more, and they can keep on asking questions. And so when we think about that self-explanation loop, why I think this is going to be a slightly more useful thing for things like clinical decision support is because this process of explanation the tool is helping you do that process of self-explanation instead of you trying to understand why the tool made a particular recommendation. And so the vision you kind of see here is something where if there's tens of thousands of possible hypotheses, it will help you narrow down to maybe a dozen or 5 and say, these are the 5 things I likely think. Which do you think is the most likely? Let's explore together. And so to give you a quick demo here, I'm just going to switch. Hopefully you can see, somebody give me a thumbs up if they can see a screen now with the tool support. So this is a study we're about to run in dermatology. So we've been working with the chair of dermatology, Peter Sawyer at UQ, Monica Janda, who's head of Centre for Health and Health Services at UQ, Lena Bielkowski, one of my colleagues, and Chongbo Zhang, who's my postdoc. I'm just going to minimize this window here. So here we have a simple example of trying to diagnose whether this is a skin lesion. And what you can see here is this is kind of the evaluative AI thing I did here. So I'm going to walk you through it because it's a little bit complicated. But on the left, on this thing here is these are different diagnostic criteria that dermatologists use. These are slightly out of date now. I think there's some new ones coming up at the moment. So pigmented network, and along here you sort of see the AI has identified, the machine learning algorithm, whether these things are present. So in this case, it says there's a sort of a very typical pigmented network. You can see by this bar here, it thinks it's highly, so probability of 1. The vascular structures that you might see in these things is probability of 0.96 that it's absent. That's what ABS means. And things like these dots and globules are regular. And so it's identified these diagnostic criteria from these images, and we can kind of click on it, and I don't know how well you can see that because the line is almost the same color, but you can see here, this is what it thinks is the pigmented network. This one's absent, so it's not highlighting anything, but it's highlighted some dots and globules, probably not really well, actually. That doesn't look like a good segmentation here. And what we give is, here, it then gives you a probability of whether this is a nevus or a melanoma, so benign or cancerous. And here we're actually giving the probability. You could say that's a distraction, but what we actually do here is say, well, if I think it's a nevus, it gives me, well, this is the evidence that supports this is a nevus. And if I say, no, it's a melanoma, it says, well, there's no streaks, and melanomas typically have streaks, apparently, and there's regular dots and globules, which are unusual in melanoma. And I can query other types of diagnosis as well. And if I can set one of these to my primary and my differential diagnosis here, but I think one of the important things that we want to play with in this, so that's kind of a pretty much an evaluative AI view. This is the view that I'm having. One of the things that we're interested in playing with here is saying, but if in this case here, I think the dots and globules, I actually think they're present, but it hasn't highlighted it very well. But in this case, the GP or the dermatologist can say, actually, I disagree with this, so I want to change the answer to these dots and globules are absent now. And I think there's streaks in here. I think there are regular streaks, and I do this. And when you do that, it changes the probability of these diagnoses here. So I could really go through and change as many of them as I want. If I change all of these ones here, it starts to go down. This one is pretty certain of here, but often you see that the probabilities will switch around, and the AI suggested primary diagnosis will switch around. And so we want to experiment with whether being able to say, no, the tool got the evidence wrong is actually a helpful part of this experiment, this tool or not. But you can see here, this is slightly different to the idea of just providing a diagnosis and an explanation. You can see the diagnosis, you can kind of see this is the explanation why, and this is the explanation why here, but the mode of interaction that we're using is different. And so to answer the question, is explainable AI dead? The reason that I said long lives explainable AI is because actually this is built on an existing explainable AI model. This extraction of concepts is an explainable AI model called concept bottleneck models. And we've just built a machine learning tool with an explainability model, and we're using it in a slightly different way, taking it from bluster to prudence. And I think there is a lot of scope to just use existing tools to build slightly different decision support tools that I think will have a better impact. So we're about to run this study, but we did a much more basic study earlier in dermatology and found it didn't make much. It was a very small cohort, didn't make a great deal of difference to the decisions they were making, but they felt a lot more in control. The agency was stronger. They felt it was a lot better for helping them develop the necessary skills or not erode the skills, and that it was a much nicer interaction. So is explainable AI dead? I don't think so. I think the tools that we've built are there, but long live explainable AI, because I think we just need to start to use these tools in a slightly different way that we're doing than we're doing now. So thanks very much for your time, and I'll finish there.
Thank you very much, Professor Miller. So that was absolutely fascinating. So I do also have a background in explainable AI, and what you've said there makes so much sense to me. We do have a couple of questions in the chat from various people. Thank you so much for asking your questions. And if anyone has any more questions, please feel free to keep putting stuff in. So our first question comes from someone, comes from some people actually, I think, because he raised his hand.
Sorry, Maitreyi, that was an accident.
Okay. So our first question comes from someone who's asking about some of these studies that do the comparison of just the doctor diagnosis versus just the AI versus the doctor plus AI. So have there been any studies that take these comparisons to successful clinical outcomes with the patient as opposed to just diagnostic accuracy? So thinking over time, the therapeutic relationship might support patient engagement, better communication, improved diagnosis, and ultimately better outcomes.
Well, I think the answer to that's probably no at the moment. It's not got that far yet. It's all in silos and in the research, and either in a research position or in a general sort of playing sort of setup at the moment. So, but I'm really interested in what Tim's been, saying about explainability and about how you interact with it. That's a really revealing concept to me, that the way in which AI supports rather than just takes over.
Yeah, I mean, to answer the question, Charlie's right. I mean, in Australia, very few. There's very few even tools in use, let alone in clinical trials. The Mayo Clinic, along with somebody, maybe Stanford or something, is running a long-term trial on the use of biomedical large language models in hospitals that you can read up about. I haven't seen the outcomes of those yet, but that's easily the most advanced one that I've seen, which is incredible because it's one of the newest technologies. As well. But I mean, I kind of think that's probably one of the technologies that will have the biggest output, precisely because you can get these interactions by default. And I think doctors will tend to use it a little bit more, skeptically than, for example, university students completing assignments. So I think we might see some success there, but who knows?
But MedCalc, that calculation application app that I showed on my phone, I mean, everybody's got them on their phone, but very few use them. You use them when you're being challenged. You don't use them routinely. It's too time consuming.
And that's interesting to think about as well, isn't it? When it might be used as opposed to is it going to be used in every situation? That's a very interesting point. Sorry, were you saying something?
I mean, I've got to say, what we observe in dermatology, for example, 80% of cases are very easy, even of photos that are taken by a melanographer, the dermatologist. It doesn't need a support tool. And that's kind of what the workflow we're trying to work on now is just get them to click through. And then when they get stuck, get Prudence to help them.
We have another question from someone who says they've actually got lots, but they've just posted one in the Q&A. So they've said, in making a diagnosis on the basis of uncertain information, so like with a test that's not 100% accurate, the chance of making a correct diagnosis depends on the prevalence of the condition. So this applies to anyone, human or AI, trying to make a diagnosis. And our tendency to forget about this is known as the base rate neglect. So do either of you have any thoughts about this in relation to the use of AI in support of medical decision-making? And I think this ties in quite neatly with the point you were both making as well.
Tim, do you want to go first with that?
Look, I'm happy to. So how much time do we have? So I think that's it's definitely something that's quite straightforward to, let's say, explain to somebody. It does show that people struggle to understand when you explain these types of things unless they're already well trained in them. But also it's I'm going to go on a little bit of a tangent here. The base rate neglect, that's sort of that's come out of a lot of these cognitive science experiments, and I'm a little bit skeptical about some of those things. So there's now some evidence to suggest that all those experiments that Kahneman and Tversky ran about base rate neglect only occur in certain situations. And so they used to use vignettes, what they call vignettes, where they'd give a little story about somebody and then you had to answer a question. And it shows that people sort of somehow don't interpret base rates properly. But actually, if you structure the information in slightly different ways, people are quite good at considering base rates. And so I think it's probably not that difficult to get. I don't think it's actually as big a problem as what people think, unless you present information in the wrong way. And it seems that probably if you could present it in the right way, people would use the base rate quite easily. And it's not sort of, I'm not talking about just general people, but in the context of medical decision making, this is people who are trained to think about these things. So they probably could adapt to it quite well, which is not a bad idea. I'd like to think about it more in some of the studies that I'm doing.
And I suspect that AI could be trained to take base rates into consideration a lot easier, training clinicians to do that.
Yeah.
And I think we've got time for maybe one last question. So one of the things that you've both talked about actually is this idea of complementary performance, where the doctor and the AI working together often don't produce as good of a result as could be expected or as could be justified. So do you think this is something that can be improved over time as doctors become more and more familiar with different AI tools, as we train AI to be better at doing specific tasks? Do you think this performance of the teamwork, the paired performance, could actually be improved over time?
Well, I'm sure that's a Dorothy Dix question, and it's very obvious that we haven't got a clue how to work with it at the moment. We're not, it's just started and we're not sure how to work with it. And I think it's giving us a very good direction for how we need to teach medical students to work with AI. And there's some enormously exciting, work to be done to get the next generation to function better. So we know that when you just throw it to doctors at the moment, that's not optimal. So there's work to be done, and it'll be exciting.
Yeah, and I think it's good, Dorothy Dix. I think because it's a way to end on a positive note. I think Charlie's got it right. I think people when you use these tools, you need to understand what the limitations are and the types of mistakes they make. We can train people on that. It's not too hard. But then I think after that it becomes it's a responsibility of designers of tools to make sure that the tools, if someone understands the basic limitations of machine learning, for example, then the tool, you want to try and design a tool so it's almost seamless, right? So that people can use it without requiring too much additional training and understanding. And I think that's the way you see tools developed on web applications now. They change quite often and people upgrade them all the time. So they need to just be usable. And that's basically what the 5-year research plan I've got is just how can we combine Bluster and Prudence in ways that people can use them well, doesn't erode their skills, keeps them in control of the really important decisions and helps them automate the difficult parts.
Awesome. And I do see other questions in the Q&A, but unfortunately, I'm not sure if we're going to have time to go through all of them. So I might just ask one more. So whether, and this is a follow-up to one of the previous questions. So whether or not the base rate is neglected, the probability for correct diagnosis still depends on prevalence. The real question is, what prevalence assumptions are AIs making?
Well, it'll make what you ask it to do.
I mean,
won't it?
the big one. Yeah. It does. I mean, the big assumption it makes is that the future is the same as the past, right? Everything's going to look the same as the past, and we saw, the pandemic. That's not going to always be the case. So that's why this is exactly why I've got a postdoc waiting to get a visa to get into the country now. Is we're looking at things like skills erosion, and how can you design tools to prevent skills erosion, because people are going to need to still have the skills to do these things themselves, because the future doesn't always look like the past.
And medical legally, the lawyers don't mind what the prevalence is. If you get it wrong, you get it wrong. That's the problem.
Yeah.
For these rare conditions, the prevalence isn't that important. It's about whether it is or it isn't. For me, obviously that in a decision process, if you over diagnosing something because you think it's there all the time when it's rare, then that you've got to adjust for that. But fundamentally, it's the rare stuff that gets us into trouble, and the rare stuff that AI can really help us with.
Mm-hmm.
And the second thing I'd say is, that the idea that you've got an expert who's can do something really easily, you're right, but the expert isn't out on an Aboriginal settlement in the middle of nowhere. AI will make this, the standard of excellence. So AI has the opportunity to take that expertise from the expert and share it with everybody else. That's the major excitement for this for me. At the moment, we've got a few experts and a lot of people who are not.
Yeah, absolutely. But well, I think you've got people who aren't experts but can interpret what they see, and
with a bit of help, they can see what they can see and they can share it. I mean, I'm an intensive care doctor. I haven't got a clue about the ruddy dermatology, but the expert dermatologist wasn't available to me. And ChatGPT was was really helpful. I'm glad I would have been more confident doing it having heard your talk, Tim, than I was when I did it.
Very good.
But the point for me is, I want some regulation, because I'm not allowed to do that. It was incredibly helpful, but I'm not supposed to do it.
And thank you both for your thoughts on all of these questions. And with that, I think it's time to draw this webinar to a close. So thank you very much to both of our speakers for being here today and for sharing their time and their thoughts with us. And thank you very much to the audience for all being here as well. So if anyone has any further questions, you're welcome to contact both speakers after the session today has ended. So just a quick question on how you guys would prefer to be contacted. Would you prefer to be contacted via email? How would you prefer to hear from anyone interested in meeting with you guys?
Tim?
Yeah, email, LinkedIn. I'm also on Blue Sky.
An email for me too. It's just much easier. Thank you. I'll be happy.
Thank you very much. It was very fun.
Thank you.
Perfect. Thank you all for being here. And I can see in the Q&As a few people saying, I wish we could discuss this more, and thank you for the excellent discussion.